Hello, my name is Jim Blando, and I'm an associate professor at Old Dominion University in Norfolk, Virginia. It's my great pleasure today to present a research project that my colleagues and I have been working on over the last several years for the Air and Waste Management Association's 114th Annual Conference and Exhibition. The title of the project is Delayed Respiratory Response to Wildfire Smoke. I'd like to acknowledge my colleagues who are also co-authors on this presentation, Michael Allen, who is a member of the geography program here at ODU, Hadiza Galadima, who is our biostatistician, Tim Tolson, who is a clinician who graciously agreed to collaborate with us on this project, Muge Akbanar, who is an associate dean in the College of Health Sciences, and Mariana Slowcox, who is an associate professor in the School of Community and Environmental Health. This project looked at the public health impacts of wildfire smoke on a community impacted by wildland fire. So before I begin, just provide a little bit of background. I'm sure everyone's well aware of the issues surrounding wildfires as they have increased in prevalence and frequency and magnitude over the last several years. Wildfire, based on the definition at ready.gov, is an unplanned fire that burns in a natural area. One of the issues associated with wildfires over the years is an increase in what is often termed the wildland-urban interface. This is essentially where urban development has been encroaching on natural areas, bringing communities in much closer contact to natural areas subject to wildfires. The consequence of this is when there is a wildfire, there's a lot more potential for property damage and injury and death. One of the things that's misleading about wildfires is that the speed of spread can be deceptively fast, and oftentimes this can result in fatalities and injuries. Many common causes of wildfires are listed here on the slide, but you will note that 80% of wildfires, based on a Department of Interior survey, was associated with human activity. So the majority of wildfires are oftentimes caused by human activities on these wildlands. There are some natural causes as well, lightning strikes being a very common one as well. It is noted there are several studies that have been published in the last 5 to 7 years that have shown an increase in magnitude and frequency of wildfires, and this is thought to be related significantly to climate change. Goes without saying, anyone who's experienced or lived in a community impacted by a wildfire will note that there are significant air pollution emissions from a wildfire that can be incredibly widespread. This includes all the criteria air pollutants, as you know, but also includes many organics as well, ultrafine particles, and can include secondary pollutants also. Wildfires include burning of natural material, which releases a lot of organics, but it's also important to note that not only are wildlands burning, but as the wildland-urban interface increases, when there is a wildfire, oftentimes many objects of modern convenience and modern society also are burned. Things like automobiles, structures, many synthetic materials, and this can add to the air toxics burden resulting from wildfires as well. Just to give you some reference, high levels of air pollutants are very common. You can see here on the slide that the Camp Fire, California in 2018, the PM 2.5 24-hour emissions levels, particle levels were significantly above the EPA National Ambient Air Quality Standard. And it's also important to note that the transport of these pollutants can occur locally and over long distances as well. You'll note in this picture on the slide that this is actually an old photo from 2001 where there was a wildfire in Canada, but you can see that that is not cloud cover, that's actually a smoke plume that impacted the entire Northeast. So it can have long-ranging impacts as well over great distances. So it's well known for a long time that wildfires and smoke from wildfires can increase, it can have an impact on public health. And many of the studies have shown increases in hospital admissions and emergency department visits. There also are some studies out there that have showed increase in asthma medication use and self-reported symptomology for people exposed to wildfire smoke. There also is some information out there that was of great interest to us because of some of the data that we were analyzing for this particular project, that perhaps smoke from combustion can also potentially result in allergic sensitization. There are many studies out there showing that cigarette smoke and wood smoke are associated with new onset asthma in exposed children. There are plenty of studies that have demonstrated in uterine exposure may increase the risk of young children developing asthma. But there are also, although it's a lot less clear, there are also some studies out there that have shown that new onset asthma in adults a risk factor for that may be exposure to smoke from combustion, things like wildland fires. In fact, there are a few studies from wildland firefighters in Greece that have suggested there's a potential delayed response when the data is evaluated. It is noted that the longer these firefighters serve in this role over time, the greater the increase and risk of developing symptoms such as asthma. Also, there was a recent study published very recently, Orr et al., that did look at communities impacted by wildland fire smoke in Montana, and they did show a delayed effect based on measurements using spirometry, a delayed effect in respiratory impacts as a result of wildland fires in the Montana area. Occupational asthma is well known to many industrial hygienists. It's well known that there are certain chemicals that increase the risk of development of asthma. One of the classic ones are isocyanates. There's even some biochemical literature on how that may actually happen, but essentially people do not have asthma. They're then exposed to chemicals, and over time, some of these asthmogenic chemicals result in a tremendous increase in actually the onset of adult asthma. And there are several animal studies that have shown that the combination of wood smoke or wildland fire smoke or smoke from combustion combined with things like ovalbumin or other allergens is enhanced tremendously by the co-occurrence of those two exposures. So there is some information out there that suggests maybe it is plausible that exposure to wildland fire smoke may result in allergic sensitization and either being sensitized to the wildland fire smoke itself or increasing or priming the immune system such that it is more responsive to common allergens one might be exposed to, resulting in a delayed response or an observation of an increased response at some time removed from the actual exposure. So this was of great interest to us, primarily because of the data that we were looking at and some of the observations that we had in this observational data set. So we were particularly interested in the Dismal Swamp, which was, and you can see here, for those of you not familiar, I don't know if you can see my cursor, but you'll note that it's in southeastern Virginia, northeastern North Carolina, right on the borders where the Dismal Swamp is located. And we had two significant fires in 2008 and 2011. Interestingly, these fires were peat land fires. There's a lot of peat in the ground, which adds some unique characteristics to these wildland fires because they're extremely high organic content. They also burn underground. They're very difficult to control, but they also release a tremendous amount of organics for the air emissions that they release. So our hypothesis essentially was we wanted to look at these Dismal Swamp wildfires and see if we could see clinically relevant measures of respiratory health impacts from these wildfires in a community that was impacted by these fires. We did not want to look at the more severely ill people that were ill enough to be admitted to the hospital. We sort of wanted to try to see if we could capture the bottom of the iceberg, people that are not sick enough to be admitted to a hospital but might go visit a clinic. So what we did is we were able to recruit a clinic in Elizabeth City, North Carolina, and look at their clinically relevant data to test this hypothesis to determine if the Dismal Swamp actually impacted the respiratory health in this community. These are some of the demographics of the community, fairly typical, classified by the U.S. Census as an urban cluster with rural areas. From having grown up in the Northeast, I would say Elizabeth City is a fairly small town, fairly rural with some heterogeneity and poverty in the area, and these are the demographics for that community. So what do? We conducted a retrospective epidemiologic study using an observational longitudinal cohort study design. This study was not designed to show causality. This study was designed to look at observations and see what we could observe in a real community impacted by a real wildland fire. We wanted to utilize clinic measures, and we utilized a longitudinal repeat measures design. We had demographic information and biometrics. The principal clinic measure that we ended up settling on was a peak flow measure in liters per minute, which is a very common thing that is oftentimes used, especially for patients with asthma or allergic symptoms. And you can see here, this in the upper right corner is a picture of a simple peak flow meter. Essentially, the patient breathes in, forces their air into this peak flow meter, and it measures their expiratory forced air exhalation flow or volume flow. Oftentimes listed in liters per minute. For a typical adult, it's usually around 400 to 700 liters per minute in that initial blast into the peak flow meter. And these values do vary by sex, BMI, pre-existing health, and age. But that was the principal measure that we wanted to look at. Peak flow, there are models that are out there where one could predict what you would expect for any given patient. Those values are useful because it helps the clinician determine or interpret the peak flow that they're seeing at the clinic visit for the patient coming in to be seen. So what do? We wanted to look at these peak flow measures, and we wanted to look at two different measures. We had the predicted values based on these models that one would expect for a patient, but we also had measures of a patient's personal best. Many of these patients are longtime patients at this clinic, and therefore the clinicians had a history on all of these patients and had their sort of personal best peak flow. So this allowed the clinician and allowed us, when we looked at the data, to compare how were patients doing on their individual clinic days that they came to the clinic compared to what would be predicted and compared to their personal best. We developed a metric that we utilized to assess this performance, and they're listed here. We referred to them as delta predicted or delta best. Delta predicted is essentially the clinic recorded value on the day of the patient's visit to the clinic minus the predicted value one would expect for that patient. The delta best value was the clinic recorded value minus the patient's personal best. Therefore, a negative value shows that they're performing below or have a lower peak flow than one would have expected from their predicted or their personal best values. In other words, perhaps there may have been an impact on their respiratory performance, and that could be impacting their clinic visit and their evaluation. We wanted to look at temporal trends, and we wanted to assess two fires. The dates are listed here on the slide. But one of the things that we tried to do in this study is we recognized that there is a lot of seasonality associated with air pollutants and especially allergens, and these are patients that are coming to an allergy clinic. So how can we try to control for that seasonality so that maybe we could see more of the impact of the wildland fire smoke and less of the impact of these allergens? Well, how we settled on trying to control for this as best we could was, rather than doing the time period immediately before the wildfire and the time period immediately after, which are going to be two significantly different temporal periods, we decided what we would do is we would keep the same calendar dates from the period of the fire, the during fire period, and we would look at the same calendar dates 1 year prior, the pre-fire period, and 1 year after, the post-fire period. The benefit of this, we felt, was that it would allow some control on the seasonality of things like allergens, because we're looking at the same exact calendar dates when we do our comparisons between the pre, during, and post-fire periods. So for example, fire number one, the pre-fire period, was in 2007, the same calendar dates as the fire that occurred in 2008, and the post-fire period was in 2009, the same calendar dates as the fire in 2008. We also attempted to utilize meteorologic data to try to use this as a surrogate for potential exposure to wildland fire smoke. Now, this has significant limitations, as you are all aware. The issue that we had is there was no air quality data available to us. This project was very data limited. There was no air quality monitoring that was done. There was some measurements taken, satellite measurements we didn't feel were robust enough for our purposes. So what we settled on trying to use as a proxy for exposure was simply wind direction and wind speed. And essentially what we were trying to do is compute the percentage of time somebody was exposed to a downwind condition or an upwind condition. If the wind, since the Dismal Swamp was northwest of Elizabeth City, if we had a northwesterly wind, meaning the wind was blowing from the northwest to the southeast, in other words, Elizabeth City was downwind of the fires, we calculated the percentage of time that the wind was blowing in a direction where they were downwind from the fire, and that was our surrogate proxy as a measure, an estimation of the percentage of time they were downwind and therefore potentially exposed to wildland fire smoke. We computed the percentage of time the wind was coming from this northwesterly direction on individual daily values, but we also did a 3 and 7 day lag period. The percentage of time in the 3 days prior to a patient's clinic visit and the 3 and 7 day period of time before a patient's clinic visit and their visit to the clinic. So we utilized this as a proxy for exposure. First thing we did is we looked at descriptive values by demographics, and you will note that if we look at these demographics and you look at this value as the delta predicted, these are the averages for these individual demographic groups with a greater negative number, meaning there's a greater impact on these peak flow measures, you will notice that the post-fire period has the greatest negative values. You will also notice that females and blacks have also the greatest negative values. This is in line with what one might expect, as there is some suggestion that females are more susceptible to impacts from air pollutants. And of course, blacks or other minority groups have less access to care and therefore oftentimes seek care when the condition is more severe. So this seemed to suggest that what we were seeing in our data. But what was interesting about this is that the post-fire period, the year after the wildfire, seemed to stick out as having the biggest decrements. We also looked at a descriptive analysis, and again, to quickly just summarize, these are for asthmatics, and this is what you would expect, elderly and children most significantly impacted. But what's interesting to note is that here as well, when we look at this delta predicted value, you will notice that the largest decreases are in the post-fire period. So this got us thinking about, what is going on with this post-fire period? Could there be this delayed effect? And although we can't establish causality, it's certainly an interesting thing to hypothesize about. One of the ways we tried to get at this is we conducted a repeat measures ANOVA analysis using our delta predicted and our delta best values, although what I'm presenting here is the delta predicted values, where we essentially looked at the delta predicted values during each fire and during each period, and we found that for the different groups, now this is also a repeat measures design, which allows us to account for correlation on individual patient level data. So every patient in this data set has measurements before, during, and after the fire, the pre, during, and post-fire period, and we're able to account for, with this repeat measures design, to account for correlations on those individual level correlations that would occur because the data is patient level data. When we look at these various groups and we did our analysis, we in fact found that comparing the pre and during fire periods was not statistically significant, but in fact, when you compare the pre and during fire to the post-fire periods, that's where we saw significant differences in the delta predicted values, the outcome measures, which again indicated perhaps there's something going on with this post-fire period. You look at unadjusted raw data. This is obviously, statisticians cringe when I show this because the R-squared value is so low. The purpose of this is just descriptively to show that as we look at an increasing percentage of time that the wind is coming from the fire towards the community, you can see that there's a slight trend downward where we see a decrease in this particular slide, it's a decrease in the delta best value. So you see a bigger decrease as we have the percentage of northwesterly wind increase, a bigger decrease in respiratory performance comparing their clinic measured peak flow to their personal best. You see a bigger decrease. However, we recognize this has a very poor fit, and we didn't control for any confounders in this unadjusted data. So we thought, let's do a model where we might be able to control for potential confounders. And this is the model we ended up settling on, a multivariate linear regression. In this particular case, I'm showing you data for delta best, which again is their clinic measured value versus their personal best. You can see the various confounders here are in the model: age, BMI, sex, and race. What we were primarily interested in looking at is this beta 1 value, which is the percent of time the wind is coming from the fire to the community. What is going on with this adjusted model? And you will notice, in fact, that what we find in this particular analysis, this particular model, is that we have statistical significance in terms of the percent northwesterly wind is a statistically significant predictor of delta best, and the parameter estimate is negative, meaning that as the percentage of the wind coming from the fire to the community goes up, the delta best value goes down, right? There's a decrease in this delta best value. That added further speculation on our part that perhaps the wildland fire smoke could be impacting the respiratory performance, and this analysis was for the post-fire period. Again, is there a delayed effect? Something interesting to speculate and postulate about, and this data, in our mind, helped us speculate about that. So what do we conclude? Smoke from the wildfires may be associated with a delayed respiratory response among patients. In this case, I should mention that all this data were on patients with allergic rhinitis and/or asthma. There was this delayed effect, and it allows us to hypothesize, is it possible that wildfire smoke may act as an adjuvant that enhances allergic sensitization or primes the immune system to result in this delayed response? And in our case, this analysis was 1 year after the fire. So again, this study is not to show causality. It's interesting observations that allow us to speculate about something very interesting, and certainly it bears further exploration in the future with a more carefully controlled study. I would like to acknowledge the various graduate students that helped abstract the enormous amounts of data we had to abstract to do this project. And here's my contact information. If anyone has any questions, please feel free to call or send me an email. I'd be happy to answer those questions. Thank you so much for your time.